work, so please fix it from the technical standpoint. Thank you very much. Very pleased to introduce the next speaker, who's Professor Will Tucker from Moffitt Hospital, who's going to talk about investigations workup of posterior uveitis.
Thank you, Prof. Neri. I'm not a professor, but you are. So I'm very pleased to be back here for my third year on the uveitis course, and thank you to Carl and Carlos for inviting me originally. So I'm going to be talking about the investigational workup of posterior uveitis. That's an important distinction because obviously there may be a few tests that we would do differently if we were talking about anterior uveitis. So where do the investigations fit into the management of uveitis? Why can't we just do the same list for every patient? And what and when should we test? So Ilaria has already given us a schema for how we might investigate and manage a uveitis patient, but essentially we have a history and examination, investigations, and then medical and or surgical management. And investigations come after the clinical assessment, as has been espoused by Ilaria there in the hierarchy, and should be complementary to it. An important point here is our arrows always lead back to the diagnosis potentially, so we can always change our mind even after medical and surgical management. We often have to revise our diagnosis, and we shouldn't be afraid of returning and repeating these things later on to make sure the diagnosis is correct. So why do we do investigations? Well, obviously we want to try and establish the etiology of the uveitis and or any underlying systemic disease, exclude the differential diagnoses, look at the assessment of the disease extension severity, assess the safety of our actual treatments that we're doing, and check the response to treatment and prevent complications from them. So there isn't a list that I'm going to give you per se, because there's a lack of an agreement on a standardized protocol, and it's important that we do try and take a personalized, patient-centric approach, thinking about the anatomic and clinical classification of the uveitis, thinking about our differential diagnosis, carefully selecting our diagnostic tests in a time of financial hardship. We need to make sure we don't waste money unnecessarily, and have knowledge of the strengths and weaknesses of each test. So we always investigate posterior uveitis, panuveitis, and intermediate uveitis, and that can include cases where the diagnosis is clear from our clinical assessment. This is the case of toxoplasmosis, which is fairly clear, and some people may say, well, you don't need to investigate, it's toxoplasmosis, but of course, it's worth establishing baseline blood counts, liver and kidney function, prior to giving them potentially toxic treatment, and there may be atypical features that would mean you might want to consider HIV testing. So it's not true that we don't investigate all posterior uveitis, we certainly do. So again, Ilaria's covered this already. We think about the phenotypes when we come to our investigations, and these are our various types of investigations we can do. We're obviously going to concentrate on the blood testing here. So full blood count. It can tell us about the overall health of our patient prior to us giving them potentially toxic medication. Occasionally you may see eosinophilia in a parasitic disease. You may see changes in the lymphocyte count and sarcoidosis. And an important point, and one that does occasionally come up throughout your career, is that you will occasionally diagnose somebody with a masquerade, a leukemic syndrome, from their full blood count. And this is a case of a CLL infiltration of the choroid that was confirmed by the full blood count, showing a white cell count in the hundreds. And of course, with the full blood count, we can assess the side effects of treatment over time. So our kidney function, urine electrolytes, systemic diseases obviously that affect the kidney could show up here, and we want to look at treatment side effects. And I've introduced this very recently to my presentation as a sign of where our basic blood tests can help. So this is an 86-year-old woman, recent hospital admission, multiple comorbidities. She has a fungal lesion. So she was put onto voriconazole, 200 milligrams for the first 2 days, and then 100 milligrams a day. I'm just going to show you her urine analysis, her urine electrolytes tests over time. And as we can see, she started her voriconazole treatment on the 15th of July. And unfortunately, as we can see here, within the first week or so, she started to develop hyponatremia. And this probably went a bit unrecognized at that first visit, and maybe even the second visit, although the number was already starting to trend quite worryingly downwards, where 120 millimoles per liter of sodium in your blood test is enough to give you really severe signs of hyponatremia and potentially, certainly in an at-risk patient, put you into a coma. So we did stop the voriconazole eventually, and as you can see, her hyponatremia resolved. This is a known side effect of voriconazole, and it can be deadly. And so it's worth knowing about the side effects of your medications when you're giving them, and then using your simple blood tests to monitor for them. So liver function tests can be raised in sarcoid, and again, can show the side effects of our treatments. ESR-CRP may be useful if they're high, but usually they're kind of medium high, and they end up confusing things further. They can be good to monitor for treatment response and recurrence in certain conditions. So ACE, angiotensin converting enzyme, and then soluble IL-2 receptor. It's a non-specific marker, unfortunately, for granulomatous disease and sarcoidosis. It becomes more specific the higher the level. It should really be used to add weight to the diagnosis when supported by other features. And serum IL-2 receptor levels aren't commonly used yet, but they are more specific. And what do we mean by that? So we have this forest plot here, and we're just demonstrating the fact that there's a fairly large overlap between controls and cases for the ACE levels. So if you have an ACE level of 45, you could be a non-sarcoid patient, or you could be a sarcoid patient. The higher the level, the more specific it becomes. The overlap between the controls and the cases is less for the IL-2 receptor. So here, where you have an IL-2 receptor level of 1700, it's much more likely to be actually a true case of sarcoidosis. So TB testing, quantiferin gold testing is our standard in the UK. Pretty sensitive, pretty specific compared to the PPD skin testing, but it's less useful, obviously, if the patient is from an endemic area. And it's likely generally useful to do if you're going to be starting immunosuppression, because it's worth knowing whether they have TB before you immunosuppress them. I put up these pictures after Ilaria's talk. We can probably already tell this isn't actually TB choroiditis. This is actually a sarcoid choroiditis, but this was a patient from the Congo who presented with this sarcoid multifocal choroiditis and had a positive quantiferin gold. And so he went on to receive a year's worth of TB treatment alongside high-dose systemic steroids, and his eyes obviously improved with the steroids. And as soon as we tapered down off the steroids, thinking that we treated him for his TB choroiditis, his disease immediately returned, showing us that unfortunately we were wrong and it was sarcoid choroiditis the whole time. But obviously we weren't wrong to treat him for his TB. It was worth doing so that it can always be excluded in the future. So syphilis, the great imitator. When I was at medical school a few years ago now, RPR, the non-specific test, was the first test that was talked about. It's useful for the rapid confirmation and can show disease load, and so therefore you can monitor it as you treat the patient. And then at the time, treponemal antibody testing was a bit more expensive, and so although much more specific and can be used for this diagnostic confirmation, it was less done. Nowadays, the RPR reagent is used, the reagent that's used in the RPR test is actually also used in COVID testing, and it became essentially incredibly expensive very quickly a few years ago. And so now the CDC in America, and we follow this as well, recommends a reverse testing methodology, where you start with what is now the cheaper antibody test, which is very specific, and then confirm the active infection potentially later, and then you can monitor the active infection later with an RPR test. But we do syphilis testing in all cases of posterior uveitis, and essentially most cases of uveitis that end up coming to Moorfields as a tertiary referral centre will get a syphilis test. Toxoplasma, I mean, it may have a place. It can be useful if negative, which can be occasionally useful for exclusion in cases of dense vitritis. And we do still pick up the occasional case of fresh toxoplasma with a positive IgM testing as well. HIV serology, hepatitis B serology, we tend to do these a lot more than we used to because it's now part of our standard practice ahead of starting immunosuppression. But you may also have other reasons to test it alongside syphilis in a high-risk patient potentially. And make sure you warn the patient before testing as well that you're doing it. I usually just say we're ruling out some infections and name them so that the patient doesn't get too surprised later on if it does come back positive. And then based on your excellent history that you've already taken, you may then consider testing for the rarer infections, although these are questionable in their utility. So HLA markers, This originally didn't say 99%. I've changed it, and this is absolutely my feeling as well, alongside the talk you'll hear from Carl later in the course, that the HLA-29 association with birdshot is 99.99. There's probably an exception somewhere, and so we don't quite say 100%, but it's an extremely high disease association, and so when you see that choroidal disease, it's worth checking. HLA-B51 has fallen out of favor, certainly in my practice and in the UK, mainly because it's probably only positive about 50% of the time, and so is that a useful test or not? It doesn't mean you don't have Behçet's if it's negative, and Behçet's is a clinical diagnosis. And then we're not going to go too much into autoimmune rheumatological testing because that is a big rabbit hole. You can do it as part of a workup for a systemic vasculitis, ANA, ANCA, but the chance of blankly doing ANAs in every patient is a problem, because the chance of a positive ANA of around 1 in 125, which is the dilution factor, discovered as part of your AAU, your workup for anti-uveitis, being a sign of the fact that lupus is the cause, is less than 1%. So extremely low likelihood of actually bringing anything to your diagnosis. Urine analysis, most useful in cases of scleritis to make sure they don't have ANCA vasculitis, but you can look for blood casts and coexisting infection. ECG, I've added this recently, so this is a good test for everybody if they can remember what the little M in the V1 lead means, which is right bundle branch block, in case you had forgotten. So there's a little bit of controversy around this. Again, it's similar to other things where it can be useful to do potentially if it's abnormal, but because there are 16% of sarcoidosis patients who do actually have ECG abnormalities, and then if you find it, it can be useful to then refer them on. However, cardiac sarcoidosis is a very difficult diagnosis to make, and often the cardiologists themselves struggle to make it. They do cardiac MRIs, they do extensive conduction testing, and so of course a normal ECG doesn't rule out having cardiac sarcoidosis. So the most appropriate management step with a sarcoidosis patient is to refer them onwards to a multidisciplinary team who can do some of this testing guided by other factors. So radiology, I'm going to show the case next. So we do chest x-rays for bilateral hilar lymphadenopathy, which can be sensitive and specific for sarcoidosis. We may show signs of infection. We may show active TB lesions. We know that high-res CT chests are more sensitive. Then brain MRIs. Our main reason that we start to think about brain MRIs is around demyelination, looking for MS, essentially, in retinal vasculitis patients. That's again become more important because we have to do that prior to initiation of anti-TNF therapy, certainly in potentially at-risk groups like patients with intermediate uveitis. It can be done if you have coexisting disc swelling or other signs of neurological disease. And a point that's come up in the last few years is around AMPI. So AMPI can be associated with the cerebral vasculitis. And in fact, there are cases that are going to be reported in the literature, and this one is from a few years ago, but there are some more coming out soon that we've heard about anecdotally of patients dying of cerebral vasculitis, and perhaps dying of cerebral vasculitis because, unfortunately, the ophthalmologist didn't act quickly enough to refer them onwards for testing for their cerebral vasculitis, which could include a brain MRI. So please do remember that. Certainly any AMPI patients with headaches or other neurological symptoms, please act quickly to ensure somebody who understands cerebral vasculitis sees them. So I'm just going to show this case. This is a great case of a young 24-year-old Caucasian oil rig worker who presented out of the blue with this lesion in his left eye and very little else to see apart from this large choroidal lesion, deep lesion, as Lara has explained to us how to examine. So his chest x-ray was relatively, his blood test was all normal, and his ACE was 24. His chest x-ray showed some possible signs of bilateral hilar lymphadenopathy, but the key here is to show you what happened when he went into the CT scanner. So this chest x-ray was considered to be potentially showing signs of sarcoidosis. And what I'm going to show you next is the slices from his CT scan of his chest. And so this is a high-res CT chest. So the windows are made so that you can see all the lung architecture very easily. And this is a young 24-year-old non-smoker, otherwise fit and healthy, doesn't know that he has exercise intolerance or any other problems as well. So as we flick through here, even us ophthalmologists in the room can see that these changes in the lungs are not normal, certainly not normal for a young 24-year-old man. And actually what we see here is the reticular changes in the lungs that are typical for sarcoidosis. He went on to have a biopsy confirmation of his sarcoidosis later on. So I'm not going to dwell too much on intraocular sampling because we have other talks later on in the course around viral retinitis and the importance of it there. Worth saying for chorioretinal biopsy, it does still have a place in our practice, and in fact, unfortunately, the fundus case, the fungal case I showed you before, actually went on to have a chorioretinal biopsy because of we were unable to establish the diagnosis through multiple vitreous samples. So it's usually a last resort. As the risks are high, essentially you're taking a chunk out of the eye, and the eye doesn't like that, and it bleeds. Certainly if it's anywhere close to the important structures in the eye, you may be risking the vision permanently. For that reason, it's probably most relevant excluding malignancy prior to high-dose immunosuppression. And then, intraocular fluid sampling, AC, vitreous taps. We could argue to the sky around what's most relevant, an AC or vitreous tap. Probably the most important thing, obviously, is getting a sample and getting enough of a sample that the lab can test it. Because the worst thing you can do is go for an AC tap and send 50 microliters to the lab, and then they come back saying, well, we couldn't do any of the tests. And then you have to go back to the patient and say, we need to test again. So getting a decent sample is the most important thing, and that may include having to take them to theatre to do the testing as well, instead of having to do it in the slit lamping clinic. So what can we test with PCR, polymerase chain reactions? So we can test for VZV, HSV, CMV, 16S panbacterial, and then 18S panfungal based off the ribosomal amplification of ribosomal DNA within those bugs. Toxoplasma and Mycobacteria and Treponema can all be tested in PCR, though they're much less commonly done, and usually you run out of sample by the time you get down to those tests on your list. And then masquerade can also be looked at with intraocular sampling with the IL-6, IL-10 ratio, cytology testing, and then, as will no doubt be talked about in multiple other masquerade talks at this conference, MID88 testing. We no longer, in the UK at least, do Goldman-Whitmer coefficient. I know it's a very useful test in some people's hands. So we'll just finish up with this question, really, which is, okay, we've talked about a lot of things. What should we be testing for? So my standard starting set for posterior uveitis, and this almost certainly has to be your own individual one, because most institutions cannot necessarily agree, or even within an institution agree. So we do the full blood count, the kidney and the liver function. Always do an ACE, sometimes do an IL-2 receptor if I think it may be confirmatory or not of sarcoidosis. Pretty much always do syphilis serology. Often do quantiferon gold, certainly with posterior uveitis. We'll send people for a chest X-ray, as it may well show some important signs. And then in our hands again, at a tertiary care institution where you're sent the patient with posterior uveitis and you think they may end up getting immunosuppression, you might as well, at that early stage, do the HIV, hepatitis B and C serology testing if you're going to give them second-line immunosuppression soon anyway. And then base that additional diagnostic testing on your history and examination and imaging. If you see retinitis, potential infection, then do a PCR tap. With choroiditis, you may think about the chest imaging. PET scan is the next test in line for sarcoidosis after CT chest. And then if you see retinal vasculitis, particularly affecting the arteries, and you're not worried about ARN, then you may start to look at those more rarer rheumatological tests, the double-stranded DNA, ANCA, ANA. You may do some sarcoid testing for periphlebitis, as we've seen from Ilaria there. And then our choroidal lesions, of course, you've already done your syphilis testing, so you don't need to repeat that, but you may then go on and do the HLA-A29 testing, and then masquerade sampling as well. So just in summary, it's important to take that personalized, patient-centric approach, be led by the clinical assessment, and be complementary to it with your investigations. Rule out infectious uveitis prior to starting immunosuppression. Base your investigations on the anatomic and clinical classification of the uveitis. Consider your differential diagnosis, and please rationally select your diagnostic tests. Thank you very much.
Thank you. Thank you very much, Will. Thank you very much, Will, for the beautiful presentation. It's now my pleasure to introduce a person that doesn't need an introduction, Professor Karl Herbort from Lausanne, who's going to talk about